today's discussion is on portocaval anastomosis. Now I tell you, the major part in abdomen, all the chapters which is in your syllabus, every part is important. A portal vein begins in one set of capillaries, ends in another set of capillaries. The portal vein begins in one set of capillaries, ends in another set of capillaries. Divide of valves reserves 1/3 of the volume of blood. Now you please take note that if you have a short question on portal vein, then this is one of the characteristic points you have to know. At least if you can mention this, you will get at least 1.5 marks. Okay? Formation, superior mesenteric vein, the splenic vein. See, here's the liver. Now, this is the cystic pyloric end of the stomach. This is the portal vein, superior mesenteric. And this is the splenic vein. So this, the portal vein. Now right gastroesophageal, the various drainage of the stomach, the spleen, the transverse colon, and the ascending colon, cecum, and the descending colon, pelvic colon, rectum, anal canal. Now this is a beautiful illustration that you have to sketch. Now course extrahepatic and intrahepatic. Portal vein and extrahepatic and intrahepatic. Extrahepatic outside the liver and intrahepatic within the liver. Extrahepatic part, relations. Now, if it is a long question, then you will be you have to know all this part, the relations. Now, infraduodenal part, anteriorly neck of pancreas, posteriorly inferior vena cava, right side bile duct. In the dissected specimens, hey, gup mado, mat mado. Nowadays, I don't interrupt my class. We are running through time. You have to know. এটা আর বলবো না কিন্তু বলি আরে একটা ক্লাস স্টার্ট হয়েছে তোমার শুনতে না ভালো লাগে you have this your earbuds or something put in, plug in, you hear music or connect to your friends with the phone. তোমরা একটা কাজ করবে, একটা ছেলেও যদি থাকে, if there is only single student, I will give the lectures. The rest, attendance is your priority. You give fingerprint, go and sit in the online platform. The last day, I'm just giving you an example. The student asked me the mesocolon. I wanted to explain in detail. I went to the professor's room to drink water. I came back, he's vanished. Intraduodenal part, anteriorly neck of pancreas, posteriorly inferior vena cava, right side bile duct. Please see whatever you are seeing in electronic gadgets, you feel and see it once in a lifetime. This is the gallbladder. This is the portal vein. and this is the pancreas. This is the head of the pancreas. And you see the portal vein, this is splenic vein coming, and this is the intrahepatic part, this is the extrahepatic part. Retroduodenum, behind the duodenum. Behind the duodenum, the retroduodenal part now retroduodenal part, anteriorly first part of the duodenum, on right side bile duct, on left side gastroduodenal artery, posteriorly inferior vena cava. You just visualize. See the head of the pancreas, and you see the duodenum, the anterior surface where it is related. It is like the bada structure. You can feel it, you can see it. एक बार देखो. Feel it, but don't tamper or destroy the specimen. Supraduodenal part within lesser omentum. Now you see this portion, lesser omentum. In front on the right side bile duct, you can see the bile duct on the right side. Bile duct on the left side, hepatic artery. Yeah. Behind inferior vena cava, separated by epiploic foramen. The epiploic foramen, that when you read the total abdomen, the epiploic foramen. Now, at porta hepatis. Now see, anterior to posterior hepatic duct and hepatic artery and portal vein. This is the picture. Intrahepatic part. See the intrahepatic part, hepatic vein, the hepatic artery, portal vein, gallbladder and common bile duct. You take a sheet of paper and you just start, when you read, you please draw. Ekdam. Dekho. Read, draw. Tributaries. What are the tributaries? The para-umbilical vein. Now see, falciform ligament you have read earlier. This is the umbilicus. It's a vital point in the human body. In every respect. An emotional respect, that the umbilicus is connected with the mother, and 10 months she keeps it in her uterus, and there is self-talk between the child, the embryo. He gets angry, he kicks. Okay. Now this is the emotional component. Without emotion, life is nothing. Now you see, this is the umbilicus. And para-umbilical vein. Now this is the gallbladder, this is the stomach. Now you see here, this is the portal vein, 1.09 centimeters, the portal vein, the cystic vein, now right gastric vein, now 1.6 centimeters, splenic vein. Now pancreatic veins. See, main thing is that I tell you, the pancreas is there. Then he has to have a venous drainage. So you just, I want to just say that you see the veins are here. And this is left gastrocolic vein. Now this is the inferior mesenteric vein, left colic vein. This is the portal vein, jejunal and ileal veins. The jejunal and ileal veins. The whole mesentery, when you pick up like this, you see there is the vessels you can see. In live videos. But in the dead body, you open or you just see the mesentery and just see the portion. It is always, you will be shat rana. Tributaries, trunk of the portal vein, right gastric vein, left gastric vein. Now, right gastric vein, trunk of the portal vein, right gastric vein, left gastric vein, right branch receives cystic vein, left branch receives paraumbilical vein. Please, those who are fighting for honors and gold medal, please note, because from you who gets a gold medal or something like that, or honors, the examiner expects that you say something beautifully. You give some answers that it is all in the book. So, now sites of portocaval anastomosis. This is a point to be noted. So, sites at the lower end of the esophagus, at the lower end of the left gastric portal, azygos and accessory hemiazygos vein, systemic. Now this is portal, this is systemic. Yeah, esophageal vein. Azygos vein. Left gastric vein. At the umbilicus. Yeah. See one man with ascites lying in the ward like this. With ascites, huge ascites, and the patient, you took the history, alcoholic, might not have the thing, there will be other pathology, but mostly encountered. Now see, the superior epigastric veins, the lateral thoracic vein, and the posterior intercostal vein, the lumbar vein, the paraumbilical vein, and inferior epigastric vein, superior epigastric vein. Now in the anal canal, close to pectinate line, when you will be reading the anal canal, the open specimen, you will see the pectinate line, and you see in the anal canal close to the pectinate line here, inferior rectal vein, superior rectal vein, paraumbilical vein, and your splenic vein, inferior mesenteric, colic vein. Now, this is hepatic, portohepatis. Now, behind the peritoneum of the posterior abdominal wall, Professor Abhijit teaching, I think, taught you class on peritoneum. Anyway, you see, behind the peritoneum of the posterior abdominal wall, see, retroperitoneal veins behind the peritoneum. At the fissures of ligamentum venosum, right atrium, left vena cava, this is the liver, ductus venosus, and umbilical vein here, umbilical arteries, portal vein, at the bare area of liver. Yeah. In the falciform ligament, paraumbilical vein, portal, and diaphragmatic veins in the systemic. Applied aspects. Portal hypertension. Portal pressure normal 5 to 10 millimeters high mercury, and portal hypertension pressure above 40 millimeters mercury. Now this is normal. This portal hypertension 40, even 30 times more. Portal obstruction, prehepatic, intrahepatic, posthepatic. Prehepatic, intrahepatic, posthepatic. Now, prehepatic thrombosis of vein. Prehepatic thrombosis of vein. Compression of portal veins by cysts. Portal vein thrombosis, clot. See, arteriovenous malformation in spleen. The artery and bypass capillaries vein. Now, this is splenomegaly. Normal spleen size is dashed. This is the normal size, this. Now, this is the splenomegaly, enlarged. See, I told you, the spleen is in the left region. When it enlarges, then if you see posteriorly, it cannot, the kidneys are there. Then what happens? It doesn't find space, so it comes down like this. The patient is usually cachectic, thin-walled, and you can see this spleen, you can observe, take inspiration, expiration, then that will come down. It's like this. And there are some notches, the splenic notches, and you palpate from the right iliac fossa and go up to this. And you ask to inspire and expire. You can feel. And when you go for liver palpation, you have to go like this. You can see the liver coming down, it's enlarged. So these two differences there, but with ultrasonology, even that is if 1 centimeters, this thing, your enlargement, then that report is given. Splenomegaly, hepatomegaly, that is given. Now, previously, splenic, kala jar, malaria, all this type of fevers, the spleen is to get enlarged. Post-hepatic, you can see thrombosis in central vein of the liver, histological view. This is histologic view of liver. Now, hepatic vein thrombosis, severe vascular disease, superior vena cava right, constrictive pericarditis, and restrictive cardiomyopathy, right heart failure of right ventricle. Now, why I am telling you that you have to know your anatomy, because clinics, it be medicine, it may be orthopedics, it may be any damn thing. It can be your skin, dermatology. Now, so a patient with hypertension, you wait for echocardiography, report comes after 48 hours. At least you know that this is the condition of the patient and this is the problem with that. Now, intrahepatic. Now, this is the alcoholic hepatitis, fatty liver. This is the cross section, this is the histological section. Yeah. Now, necrosis of the liver. Now, you see the cirrhotic liver, nodular, degenerative, and acute liver failure. This is. Now, this is the schistosomiasis, hepatic adenoma, nodular degenerative hyperplasia. You want to see a cirrhotic liver, you go to the pathology museum. The first dead body which came to our department in anatomy, he was having a big person, ekdam mota. Healthy. Mota means I'm not saying mota. Now, he had a cirrhotic liver. So that specimen, I informed the pathology professor and we gave it to them. I think it is there. You want to see the nodularity, and this is the classic specimen in our college. Pathological effects of portal hypertension, collateral circulation, ascites, congestive splenomegaly. Now you see collateral circulation, esophageal varices. Now this is very, very important because a patient comes in the outdoor with ascites and this thing, and he says he is vomiting coffee ground. Coffee ground vomitus means the blood goes in, and with hydrochloric acid in the stomach, that changes the color, and you see this is the condition, esophageal branches of the left gastric vein. Now azygos vein, esophagoscopy view, and this is a splenogram and radiograph. See, the short gastric vein, this is the diaphragm. Now in an emergency, you have to know that any other gastro bleeding is there. But if a patient comes with ascites, cirrhosis and all this, plus he might be having portal hypertension, then if it's possible, if you have a skilled gastroenterologist, then you do your GI endoscopy. But if it is not there, you manage, you immediately request for a 2 bottles blood transfusion. When you come across this type of patient, call the 2 relatives. You just speak to them, there might be a crowd. Hey, Ami Dada, Ami Parar, Omuk. No, who's the son? Who's the okay, Dada, apni thako. Silent, apna thako, sune never. And then you tell them you have to require 2 bottles of blood, and this is the condition of the patient. Breathe for a minute. It won't take away anything from you. But they know that Dr. Babu Kotha Bolche, and this is an acute emergency. Now, I told you the other day when I was teaching you, now esophageal bleeding is more dangerous than hemoptysis from the lung. It can be acute bronchitis, acute pneumonia, and the difference is red colored blood. You don't panic, but you panic in case of hematemesis, that's gastroduodenal bleeding. It can be. Okay. Now, esophageal varices. See, this is veins are here. This is specimen. Now, endoscopic therapy, this is actually why to tell you, because they can coagulate and then you can give some varices can be clipped. So the bleeding is stopped. By the time that is being done, your blood requisition is done. Then you get it, you warm the blood and transfuse. There are also plasma volume expanders that are in the market that can be given also. Treatment, endoscopic sclerotherapy. Endoscopic sclerotherapy, this is sclerotherapy. Endoscopic. Yeah. Caput medusa. This is a short note, caput medusa. Yeah. This is the condition. These veins are there, all like a Sudarshan chakra. That is being the, now whatever I told you earlier, that the just the connection, how this is the portocaval anastomosis is occurring. The veins are now dilated and see, if you in your third year or second year or fourth year in medicine, final year, you might be given a patient with caput medusa lying down. You have to take a short note and then viva. Even you can give, it can be in MD examination in medicine. And that's a story that one Maladhari, the Tulsi Bala, one patient was admitted with ascites. And the other, they had caput medusa and all this. Another patient with ascites, but he didn't have the mala. So, जो होता ना अगले दिन पहले दिन देख लेते पेशेंट, तो one of the students said Maladhari is having caput medusa. Maladhari. So he goes and looks at the mala. It is not there. Then he sees the umbilicus. The caput is, this caput, caput medusa is not so much visible. But he is having ascites and this thing. So don't trust your whispering campaign or whatever it is, that Maladhari has caput medusa and a normal ascites doesn't have a mala. But the patient with a normal ascites was, it is not pathologically, I am not speaking, but if that type of exchange of patient is there. Just say your histological slides. Your histological slide 10 kidney bol rahe. Fifth slide is kidney. But that next batch, the slide is changed. Kidney is changed into liver. So you are very confident. उसको 5 वाले में आपको आप लिख दिया kidney, but that was the liver. Okay. Now I just want to tell you these things happen. I mean, we face like this sort of, this is a talk, not just a joke, but it happens actually. But nowadays, don't forget. I'm just wanting you to see, you might be having a patient, numerous patients, like ascites in a ward, say 100 patients is there. Medicine ward, in a hospital like this, it's expected. In future, there'll be. But then you miss. You cannot see 100 patients. You are seeing that your batch, whatever it is. So that's why I'm telling you, always draw an illustration like what I am drawing. You just write caput medusa, ascites, these vital points. So you can remember. You can give your note, plus you can tell your boss that this is the presentation of this patient. Now, formation of hemorrhoids. This is the internal sphincter, the external anal sphincter, internal hemorrhoids, pectinate line, this is the pectinate line, this is the anodum, perineal vessels, prolapsed internal hemorrhoids, external hemorrhoids. Now, this is the cross section. By this time you are knowing this is the abdomen, pelvis here, sagittal section. Now you can see the liver, hepatic leaking here. The ascites fluid leaking flows into and fills the abdominal cavity. Mesenteric leaking is a sagittal view. Now, portosystemic shunts. The portosystemic shunts, now side to side, end to side, mesocaval, splenorenal. Now, you can see the normal, this is normal, this is a portal vein, this is a gallbladder, this is the cystic duct, the inferior, this is the common bile duct, inferior vena cava, this is the superior mesenteric artery. See, now side to side, the vein is in the your mesenteric vein, this is the inferior vena cava, this is now in side to side analysis, hobnail appearance of liver, see, hobnail appearance, cirrhotic liver. Now this type of operations are being done, performed. So, side to side, now end to side. See, this is the directly, it is being anastomosis, cut off, clamped, and then now end to side. This is splenic. Now mesocaval, IV knitted graft. This is a graft, portal vein. Splenorenal shunt. This is the splenorenal shunt. This is the, yeah. Central splenorenal shunt. Transjugular intrahepatic portosystemic shunt. This is portosystemic encephalopathy, hepatic coma, encephalopathy. Then ascites, you think, or jaundice is there, might be jaundice is there, if there is any malignant growth or that gives pressure to the portal vein.